I'm Dr. Sirisha Senthil, consultant and head of glaucoma service at LV Prasad Eye Institute, Hyderabad. Today, I'll be taking you through a few case scenarios where OCT helps either in the diagnosis or ruling out glaucoma, and also trying to make an alternate diagnosis in certain conditions. So we know that OCT is very useful in the early diagnosis of glaucoma and also in certain difficult situations where the visual fields and the clinical evaluation do not match. It can also mislead us in certain situations. So let us go through the cases. Ideally, when you see a patient like this, where you can see the clinical photograph of the fundus photograph of the right eye, which shows that there is a very early nerve fiber layer defect inferiorly, and visual fields are essentially normal. So this patient has early glaucoma, but however, this is not picked up on the visual fields. And I have to tell you, even the 10-2 was not picking up this defect. When we do an OCT for this patient, you see that there is an inferior nerve fiber layer defect as depicted by the arrow in the deviation map. So this is the ideal situation where you know that there is a defect clinically, which is also picked up on the photograph, not there on a visual field or not picked up on a visual field. And OCT helps us to diagnose this appropriately. So why does this happen? We know that the prior talks would have actually gone through all of these, where a significant amount of ganglion cells are lost before a visual field defect is actually picked up on a Humphrey visual field or an octopus. So the very small nerve fiber layer defects are also picked up on the OCT. Let us go through the other scenarios. A 49-year-old lady came for a second opinion, has a family history of glaucoma. Her brother is my patient as well. He's undergoing evaluation locally as a glaucoma suspect, and she's a known hypertensive on treatment. Visual acuity was normal. The intraocular pressures were always borderline and has an open angle glaucoma. The central corneal thickness is of an average corneal thickness. So if you look at the left eye fundus photograph of this patient, has an obvious inferior notch and an inferior nerve fiber layer defect as seen on a red tree photograph as well as on a color photograph. The visual fields, if you see, do not show too many changes, but you see some depressed points in the superior hemifield in both the consecutive visual fields. However, when we do the OCT in this patient, you can obviously see in the left eye, there is an inferior nerve fiber layer defect corresponding to the clinical finding, and that is quite obvious. So this patient, because the patient was a hypertensive on medications, or she was on oral beta blockers, so the intraocular pressures were not picked up as an elevated IOP, so possibly because of the oral beta blockers, her IOP was also on the lower side. But clinically, definitely had a nerve fiber layer defect. So if you're strong clinically, we can actually pick up the changes there. One may call it as an NTG or a POAG based on the intraocular pressure. However, this patient has glaucoma that needs to be treated. But if one is not very sure with a clinical evaluation, and the visual fields are not actually showing you a defect in the area that one is suspicious about or not aware of, then it becomes very difficult to diagnose. In situations like that, OCT definitely helps to identify a defect and start the patient on treatment. And this patient, if you actually do a macular GCC, you can see a significant loss in the inferior area on the macular GCC as well. But what is very important is in this patient, on a 10-2 visual field, there is a defect that was actually not picked up on the 24-2. So I'll go back to these images. If you see, superiorly, we could not pick up the changes on a 24-2. However, clinical evaluation showed it, the OCT showed it, and when we do a 10-2, it also showed a defect that was quite significant in the superior quadrant. So that is very, very important. And hence, whenever there is a suspicion of glaucoma, clinically suspicious, one would not call something as a pre-perimetric unless a 24-2 along with a 10-2 is also performed. Sometimes the OCT can be misleading as well. So this was a middle-aged gentleman who was referred to me as an NTG, and since he was progressing despite medical treatment, he was actually referred for glaucoma surgery. His intraocular pressures were in the high teens, and on evaluation, this patient actually had a significant pallor of the optic disc in both the eyes. And when you look at the visual field showed something like paracentral scotoma, but on a closer look, actually you notice that there is a defect on the superior as well as the inferior hemifield in the paracentral area in both the eyes. So remember, in glaucoma, the visual field defect usually respects the horizontal midline, and one does not expect to see similar kind of a paracentral scotoma in the superior and inferior hemifield in both the eyes. So are we dealing with glaucoma here? Very unlikely. Okay, OCT showed significant loss of nerve fiber layer in the temporal area, and the macular GCC was completely washed out. Now take a look at the clinical photographs. So whenever you're looking at the disc, just don't look at the disc. There is significant temporal pallor of the disc in the right eye compared to the left eye, but just concentrate on this area that is between the two superior and the inferior arcades. You see that there is a significant loss of nerve fiber layer between these two arcades. So this patient has loss of papillomacular bundle as well as the NFL on the temporal area. So, and also you can see the significant pallor that was there. This color vision was defective for this patient, and near vision was also affected. And this is the 10-2, which shows significant affection of the central fields. So this patient actually had inflammatory bowel disease since several years and was on systemic treatment for the same. And on evaluation had significant deficiency in vitamin B12 and folic acid. So this patient actually had a nutritional optic neuropathy. And although he was a non-vegetarian by diet, because of the inflammatory bowel disease, possibly he had a B12 deficiency. And hence we need to remember that this patient needs supplementation of B12 and folic acid, but obviously parenterally and not orally because of his systemic condition. So he was given systemic treatment for the same, and he's continued. So we need to remember that unnecessary treatment for this patient, as terming it as glaucoma, was not appropriate. And since he was progressing, because the actual disease was not picked up, and somebody had actually referred this patient for a glaucoma surgery. So making an appropriate diagnosis is very, very important. And you know, the picture here, in fact, the evaluation and clinical evaluation and visual field itself is confirmatory. However, in situations like we discussed, where the diagnosis possibly was missed, or if you are not able to pick it up, OCT definitely helps to, glaringly show you where the defect is. So he was discontinued of all topical medications and of course was put on treatment for the actual condition that he had, which is nutritional optic neuropathy. Another young lady who was referred to us for second opinion, whose baseline intraocular pressures were essentially normal, was suspected as having glaucoma based on a large disc and thinning on the OCT. She was started on topical anti-glaucoma medications. However, the intraocular pressures before and after treatment were not very different. And the CCT was on the thinner side. So this was the clinical picture. If you see that there is some amount, the discs are medium sized. There is cupping, which is about 0.7 in the right eye and maybe 0.75 to 0.8 at the left eye. There's some thinning of the NFL that you see between the two arcades and beyond the papillomacular bundle area in both the eyes. And this is the visual field. So whenever you see a visual fields like this, it's neither completely normal, nor can you actually try and tell whether there is a particular defect here, because it doesn't show you a specific pattern. There are some depressed points both in the superior and inferior hemifield in both the right and the left eye. So this is the OCT of the patient, which shows that there was a diffuse loss of nerve fiber layer, as was also seen on the clinical photograph, of between the two arcades and surrounding the papillomacular bundle area. There was a significant loss of the GCC thickness as well. So is this glaucoma? Clinically, by looking at this, as well as by looking at the OCT picture, we know that this is not glaucoma. So this patient, on asking the relevant history, actually gave a history of premature birth with cerebral hypoxia and possibly having a hypoxic ischemic encephalopathy. See, other differentials that one needs to remember is obviously this will be a neurological cause and not a glaucomatous change, but we need to rule out the other conditions as well. So she was stopped on anti-glaucoma medications and the vision and her intraocular pressure remained stable. Another gentleman a young patient who was referred to us, an angle closure patient who underwent a YAG peripheral iridotomy earlier, and his intraocular pressure were in the normal range. His visual acuity was also quite good. So this was his clinical picture. You can see the right eye, medium-sized disc with about 0.4 cup to disc ratio. There's some amount of NFL thinning that you note in the superior quadrant. Inferior NFL looks quite healthy. The macular area looks quite normal. In the left eye, the disc as well as the RNFL and macula look quite normal. So if you look at the visual fields, there is some amount of change that you see in the superior hemifield. Again, this field defect is not, although the 10-2 is also correlating, but this field defect is not a very typical of a glaucomatous field defect. And also, if I can go back to the photograph here, you see that there is some amount of NFL thinning here in the superior area, but a visual field also showing a defect in the superior area does not actually correlate. And this patient does not have any kind of an inferior NFL change that you see. So obviously the disc and field don't correlate, but you cannot have a field defect that is present on a 24-2 and a corresponding change in the 10-2 as well. And this visual field defect was repeatable on a repeated testing as well. So we need to go beyond all these things, and sometimes we need to have a strong sense of suspicion to look for other causes as well. So this patient's OCT also could not pick up any change, so essentially it was normal. And whereas the GCC showed some thinning in the inferior area, which was actually corresponding to possibly the visual field change that we saw, whereas the 24-2 did not pick up any change. So is this early glaucoma? We are not quite sure, but what is very important is when you have a clinical suspicion and they do not match with the retinal nerve fiber layer changes that you see, you have to suspect something else. So this patient on an autofluorescence image, you can see significant RP changes, alteration that you see in the area from the disc going inferiorly, which is exactly matching the pattern of visual field defect that you see here. So this patient actually had a chronic CSCR, and that was showing the changes. On a red fundus photograph or a red-free photograph, you do not see these changes. So whenever you have a strong suspicion, another lesson that we learn is you have to go back and either check it with your retinal specialist, otherwise ask for an autofluorescence, and that shows you the RPE photoreceptor, RPE changes that are present. Or you can also do a macular OCT or an OCT in the if it is possible to do it in the inferior area as well. So from the previous case, effect correlating to some extent with the OCT, but not correlating clinically, always go back and re-look at the clinical picture and try and see if we have an alternate diagnosis. So this was yet another patient, a young patient who was referred to us with high myopia. See the refractive error is about -19 diopters. The vision and the intraocular pressure were normal. The patient was not on any anti-glaucoma medications, but was suspected as having glaucoma elsewhere because of certain changes in the visual fields and was referred to us. So as is expected, he has a very large disc with a large cupping and significant peripapillary atrophy the right side more than the left side and significant tessellated fundus. Visual fields shows enlarged blind spot in both the eyes. So if you actually ask somebody who's experienced in evaluating this optic discs, you know that for a myopic eye, this disc looks okay. And when you do a visual field test, enlarged blind spot is something we typically see in these patients. Essentially, this is not glaucomatous. However, when you are suspicious and if you're not very sure how to evaluate it, then we may end up diagnosing these people as having glaucoma when actually it is not so. And on an OCT, again, you have to remember that OCT parameters sometimes can be misleading, especially in myopes, if they have a abnormal anatomical presentation that we typically see. So if you look at the OCT here, the disc area which is shown is 3.04 in the right eye and 2.60 in the left eye. So there is quite a large disc on the right side and also a large disc on the left side, but the right is larger than the left. And this is also clearly seen on the clinical photograph. And also, you can see wherever the area of peripapillary atrophy is there, in that area, the deviation map also shows thinning in the superior and inferior quadrant. And the same thing is also shown in the OCT RNFL thickness. So if you're not sure about why this thinning of the RNFL is depicted in these OCT images, one may actually diagnose it as an early glaucoma or a moderate to advanced glaucoma and start treatment with this patient. But remember, OCT will definitely be abnormal because OCT is a structural test. And when you do a comparison of a structural a test in somebody with high myopia or somebody with tilted discs and situations where the discs are actually not normal, and then you're trying to compare it with the normative data whose optic discs are essentially normal, obviously this patient or the patient in question will definitely have an anatomical abnormality, and that meshing will output as the thinning or the red superpixels that you see here, but that doesn't mean that this is abnormal. So one needs to actually understand the basics of the OCT, need to understand how to actually use it. And if you see an abnormality, the patient may ask you as to why is there this abnormality? Why are you saying I don't have glaucoma? When actually I see a lot of red area, which means that there is thinning. Because today you have to remember that patients are also very well educated, and sometimes they go and read things on the internet and come to you. So you should be in a position, or we should be in a position to actually tell that, yes, you see thinning, but this is the reason why this is not glaucomatous. So another patient, a young patient who was referred to us as treated as JOAG since some time, and he was lost to follow up, and he was on medications in both the eyes. The visual acuity and visual fields were essentially normal. The intraocular pressures were essentially normal. This was the clinical presentation. You see that clinically, this is the right eye optic disc photographs, shows there is an NFL defect in the superior quadrant, in the supratemporal area, and the same is also seen on a red-free photograph. This is the left eye, and left eye also shows a large inferior NFL defect, which is quite broad, and superiorly there is some amount of NFL thinning, but there is no NFL defect. So the right eye visual fields are essentially normal, so possibly it's a preperimetric glaucoma. And the left eye, the 24-2 shows some paracentral scotomas, but a 10-2 actually shows a little larger defect, which is corresponding to the broad NFL defect that you see inferiorly in the left eye. So this is the right eye of the patient, which actually did not show much changes, but clinically there is some amount of thinning that we notice. In the left eye, there is a NFL defect that is noted even on a 24, even in the OCT inferiorly. And on doing a GCC, although the right eye 24, the RNFL thickness map does not show any change here. However, that the ganglion cell analysis map shows literally washed out GCC complex, whereas the left eye shows some defect in the inferior area. So this was actually not correlating, and we need to again understand as to why this is happening. So if you look at the horizontal tomogram, you realize that there is some abnormality in the way the blue and the purple and the yellow lines are. So basically there was segmentation error in this patient, and asking the patient to concentrate, blink, and on repeated testing, the GCC in the right eye was completely normal. And in the left eye showed some defect in the inferior area, which is corresponding to the RNFL defect in the inferior quadrant. So sometimes when you're in doubt, you have to go back and redo the testing because you know that this does not correspond. So sometimes the artifacts can be there, which could be like a segmentation artifact and blink artifacts and things like that. So this patient had a glaucoma, but he was not progressing. and the visual field as well as the OCT was first not matching, but on a repeated testing, it actually matched. So this is on a repeated testing. This was essentially showing a change that was not progressing, but similar to what was there before. Another example of a young patient who came to us for a regular checkup. His intraocular pressures were 20, which was normal, vision was normal. The optic disc photograph, which shows some amount of change in the left eye with a superior NFL defect. So there's an excavation with a superior, very small NFL defect in the left eye. Clinically, the visual fields in the right eye were normal, and in the left eye shows a few depressed points in the superior nasal area. Again, OCT here is not showing any thinning. When I say not showing anything, it is not showing any change in the RNFL quadrant as well as the Glaucoma map. But on a closer evaluation, you can actually see some thinning that is present, shown by the arrow here. So there is a superior temporal thinning that is present, but that defect is not reaching until the disc margin. And remember, the OCT actually measures the RNFL thinning in the calculation circle. And since this NFL thinning has not reached the area of the calculation circle, the device is not able to pick up the changes. So we need to understand that imaging definitely cannot replace the clinical skills, but you also need to remember when you're using imaging, how actually it is actually showing a change. If you see here, superotemporally, it is showing a change, but you should know how to interpret each and every part of that. And if it is clinically correlating, we know. If it is not clinically correlating, then we need to understand why this is so and try to use it to your advantage. This is another patient for whom there was some changes that were noted on the OCT, where you see that there is a lot of NFL thinning on the temporal area, both the quadrant map as well as the Glaucoma maps. And so the black depicts actually 0 microns. And you know, in OCT, even if there is a complete loss of NFL, it doesn't go beyond less than 30 microns, and that is called the floor effect. That is because the non-neural tissue also actually gives some amount of thickness measurements, and because of which you don't go down to 0. But here, the black area actually represents the 0 microns, as you see on this scale. So this is a blink artifact, and that is something that you need to understand. So to summarize, looking at all these cases, what I would say is that the first case that we discussed about the OCT, how optimally it is used in patients with very early glaucoma. In the couple of other cases that we showed, we knew that there was NFL changes that were present on the OCT, but on the clinical evaluation also there were visual field defects both on the 10-2 and 24-2, but that was not correlating to glaucoma. And we need to understand that there are non-glaucomatous conditions like neurophthalmic causes, like the nutritional optic neuropathy example that we saw, as well as the hypoxic ischemic encephalopathy example that we saw, where your disc and fields may correlate, the disc field and OCT may correlate, but not necessarily it relates to glaucoma. There can be other conditions that need to be diagnosed. There are some situations where there are NFL defects that are present, but even the OCT is not able to pick up the changes, either because it is too early or not reaching the calculation circle, or sometimes it doesn't pick up because the NFL thinning is not quite significant as far as the calculation circle goes, or sometimes it is very close to the papillomacular bundle, because of which the RNFL circle is not able to pick up, but it may be seen on a GCC map. Or sometimes if you have abnormality where it shows that there is worsening in one eye compared to the other eye, and fields and the OCT do not match, always understand that there could be errors in the testing itself. When you strongly suspect, to go back and redo the testing. Another example we saw where the visual field defect was present, which was persistently there. The OCT did not reveal the change on a RNFL map, but the macular GCC showed a defect that was similar to that of the 10-2 on the visual field, but on a clinical evaluation, they were not correlating. So you have two imaging devices that are correlating, but the clinical picture is not correlating. So to go back and relook at the eye because you're missing something there. And in that patient where there was a chronic CSER with RPE degeneration, and at RPE atrophy, that patient on autofluorescence actually showed a huge defect that was present that correlated with the clinical, with the imaging as well as the visual fields. So remember, clinical correlation and making sure that whatever you're seeing, you're able to explain. And if you are not able to explain, either going back and re-looking at the patient or going back and repeating the imaging device or the visual field is very, very important. In early defects, before we call it as pre-perimetric and we ask for an OCT, or we do an OCT, but you're seeing a defect which you're not able to possibly clinically correlate or not finding on a HVF, always remember to do a 10-2. So unless you do not have a defect even on a 10-2, you will not call it as a pre-perimetric glaucoma. So that is in gist. So OCT is an excellent adjunct. You should not use it in isolation for diagnosis. Always understand that they need to correlate clinically, understand its limitations, and when in doubt or when you're not able to correlate, always repeat the test. So I think this summarizes it, when to use it, how to interpret it, and how to correlate clinically as well as with visual fields is very, very important before we use this device to our advantage and to help our patients in the clinics. Thank you so much for your attention.